up until several years ago, PSA, which is a blood test that is drawn to detect early prostate cancer, was widely used throughout the United States. And as a result of its use, mortality rates from prostate cancer dropped precipitously. Several years ago, the U.S. Preventive Services Task Force went back and looked at international literature at PSA-based prostate cancer screening and came to the conclusion that we were over-screening our population. We were potentially doing patients harm. We were finding prostate cancer that may never have caused harm to that patient, and we were treating it. And there are side effects from prostate cancer therapy. And so the USPSTF concluded at that point that PSA screening causes harm and recommended against it. And the controversy with that recommendation, and that level D recommendation, was that it flew in the face of several decades, 2 decades, of a decline in prostate cancer-related mortality, which corresponded to PSA screening. And so providers, urologists, oncologists, patient advocacy groups went back to the USPSTF and requested additional evaluation of more contemporary data, and which is part of what that committee does. And indeed, they've looked at new data that's emerged and said, you know, for the right patient, for patients who are younger, for patients who have a family history of prostate cancer, for patients with extended life expectancies, that PSA-based prostate cancer screening is appropriate when discussed with a primary care provider, when put in the context of a longer shared decision-making process. So it isn't saying that all men between 55 and 69 must be screened for prostate cancer. What it says is all men between 55 and 69 deserve a conversation with their primary care provider, and together with their family members, with their provider, make a decision as to what's right for them. So PSA screening probably is not the right thing to do for people with limited life expectancy, for patients who are older, for patients without risk factor or with significant other medical comorbidities. Part of the initial reluctance to do PSA screening was biopsies can be uncomfortable, or there potentially are side effects even from a biopsy. But something that's lost in that conversation is there's a tremendous reassurance to know that there's no prostate cancer present, that about 60 to 70% of men who undergo a prostate biopsy aren't going to have prostate cancer. So part of that conversation with the primary care provider, part of that shared decision-making process is understanding what's your level of anxiety about prostate cancer. And yes, we're going to look for it because we're concerned it could be there, but ultimately the reassurance of the fact that it's not there, I think, plays a significant role in the patient's quality of life.